Ever felt like you're just swimming in information? Especially, when you're prepping for patient care or a big exam like the
Oh,
NCLEX.
absolutely. You've got textbooks, notes, clinicals.
Mm,
It's a lot to try and, well, boil down into what you really need to know and remember.
that's exactly why we're here. Welcome to the deep dive. We sort of act as your shortcut, taking these dense sources and pulling out the key stuff so you feel genuinely informed.
And today we're digging deep into bipolar and related disorders, using Varkarolis's Foundations of Psychiatric Mental Health Nursing, 8th edition, as our guide.
Right. And for you, listening as a nursing student, this isn't just theory, it's foundational for your practice, for the NCLEX, and honestly, for developing that empathy you'll need as a mental health professional.
So let's start by unpacking the clinical picture. Bipolar disorders, they used to be called manic depression, are chronic, they're recurrent, and actually they often go unrecognized for a long time.
That's a scary thought, people suffering without knowing why. Okay, so the textbook breaks it down into three main types, right? Getting these straight is key for assessment.
Exactly. First up is bipolar I disorder. This is typically the most severe form. You see these really significant shifts in mood, energy, ability to function, though there can be periods of normal functioning in between.
And the defining thing for bipolar I is?
At least one manic episode. That's the absolute requirement. And mania isn't just feeling happy or energetic.
Right, it's way beyond that.
It's an intense period, needs to last at least a week, usually of elevated or expansive or even really irritable mood, plus this huge increase in goal-directed activity or energy. It's often so severe, it's considered a psychiatric emergency.
So what does that actually look like if you were observing a patient?
Well, initially it might seem like intense euphoria. They're energized, need almost no sleep, feel unstoppable, maybe taking big risks. But it can shift. That euphoria can intensify into psychosis, hallucinations, delusions, or it might flip into extreme agitation and irritability. And then often there's a collapse into depression. That mix of agitation and depression is particularly dangerous, increasing risk for violence or suicide.
Okay, so the DSM-5 criteria try to capture this. You're looking for that abnormal mood and energy for at least a week.
Or any duration if they need hospitalization.
Yeah.
Yeah. And then you need 3 or more specific symptoms. 4, if the mood is just irritable. Things like inflated self-esteem or grandiosity, needing much less sleep, being super talkative, like pressured speech.
Racing thoughts, easily distracted.
Exactly. Increased goal-directed activity, but maybe jumping from task to task, or excessive involvement in activities with high potential for bad outcomes, spending sprees, foolish investments, sexual indiscretions, that kind of thing. The key is the severity causing real impairment or needing hospital care.
Got it. That's distinct from bipolar II disorder then. What's the main difference there?
For bipolar II, the criteria are at least one hypomanic episode and at least one major depressive episode.
Hypomania. So like mania light.
Kind of, yeah. It's a lower level mania.
Yeah.
Still involves that excessive activity and energy, but it lasts at least 4 days, not necessarily a full week. And crucially, this is vital for you to know that psychosis is never present in hypomania.
Ah, okay. No psychosis.
Right. And it's generally not severe enough to cause that major impairment in functioning or require hospitalization, although it's definitely noticeable.
But bipolar II is still serious,
Oh,
right?
absolutely.
Yeah.
Because the depressive episodes in bipolar II can be incredibly profound and carry a very high risk of suicide. And here's a real challenge for nurses. Bipolar II is often missed or misdiagnosed.
How come?
People might mistake it for major depression because the hypomania might not seem like a problem, or they might not even report it. Or it gets confused with personality disorders. So it's critical when you assess someone with depression to specifically ask about periods of increased energy, elevated mood, decreased need for sleep, those hypomanic symptoms.
Good point. Missing that could lead down the wrong treatment path entirely. Then there's cyclothymic disorder. How does that fit in?
Think of it as further along the spectrum. With cyclothymia, you have symptoms of hypomania alternating with mild to moderate depressive symptoms for at least 2 years or 1 year in kids and teens.
But not quite meeting the full criteria for hypomania or major depression.
Exactly. The symptoms are there. They cause distress or impairment, but they don't hit the full diagnostic threshold for bipolar II or major depression. It's like a more chronic, lower-level fluctuation.
And you sometimes hear about rapid cycling.
Yes, that's important. Rapid cycling isn't a separate diagnosis, but it's a specifier. It means someone have 4 or more mood episodes, manic, hypomanic, or depressive, within a single 12-month period. It's often linked to more severe symptoms and can be harder to treat.
And briefly, there are also bipolar disorders related to substances or medical conditions.
Correct. Just underscores the need for a thorough assessment to rule out other causes.
Okay, so that paints the clinical picture. What about the bigger landscape? Epidemiology, who gets it?
The lifetime risk for bipolar at or 2 is estimated at nearly 4%. Pretty significant.
Any gender differences?
Rates are about equal, but how it presents can differ. Men seem more likely to have legal issues or encounter violence during manic phases. Women, on the other hand, have higher rates of alcohol abuse, suicide attempts, and co-occurring thyroid disease.
And you mentioned thyroid disease earlier. That connection is interesting. Also, the book highlights a link with postpartum psychosis.
Yes, a very strong link. Experiencing severe postpartum psychosis gives a woman a 4 times greater chance of eventually being diagnosed with bipolar disorder. It really highlights how factors like major hormonal shifts and, critically, sleep deprivation can trigger underlying vulnerability.
Which brings us to kids and adolescents. This seems like a tricky area.
It really is. There's a big spike in diagnoses in kids early in the 2000s, often for persistent irritability. But the concern was many didn't actually develop adult bipolar disorder.
So they got this heavy diagnosis, maybe powerful meds.
It's exactly. During crucial developmental years, that led to the creation of disruptive mood dysregulation disorder, DMDD, in 2013, aiming for a more accurate diagnosis for severe non-episodic irritability in children. But for adolescents who do have bipolar disorder, it's serious high rates of suicide attempts, major problems functioning in school and life.
Let's talk comorbidity, other conditions happening alongside bipolar. It sounds complex.
It absolutely is. With bipolar 1, anxiety disorders are incredibly common, like 75% of people. ADHD is also frequent, along with impulse control or conduct disorders, and over half have a substance use disorder.
Often self-medication, I imagine.
Very often, which tragically increases suicide risk even further.
Yeah.
Plus, there are higher rates of medical issues like migraines and metabolic syndrome.
And bipolar too. Similar pattern.
Similar high rates of anxiety disorders, yes.
Yeah.
Also, eating disorders, especially binge eating, are more common. Substance use is still prevalent, around 37%. You often see anxiety and eating disorders linked more to the depressive phases, while substance use might crop up more during hypomania.
And cyclothymic?
Again, substance use is common, likely self-medication. Sleep disorders are frequent, and in children with cyclothymia, ADHD often co-occurs.
Okay, so we know the what and the who. Let's get into the why. What are the risk factors?
Biology plays a huge role. Genetics are significant. If you have a parent with bipolar disorder, your risk is about 15–30% higher than the general population. For identical twins, if one has it, the chance the other does too is around 70%.
Wow, that's high.
It is. It's polygenic, multiple genes involved. And interestingly, there's some genetic overlap with conditions like schizophrenia and autism.
What about brain chemistry? Neurotransmitters.
Early theories focused on norepinephrine, dopamine, serotonin, maybe too little causing depression, too much causing mania. It's likely more complex, though.
Yeah.
It might be about the balance or proportions or maybe how sensitive the receptor sites are.
And brain structure and function. What does imaging tell us?
Functional scans like PE or fMRI show differences. There seems to be dysfunction in the prefrontal cortex, that's your executive function, personality area. Also the hippocampus, for memory, and the amygdala for emotion processing.
Which would explain things like emotional lability, maybe being overly sensitive to rewards, difficulty regulating emotions.
Precisely. And there's even evidence suggesting some loss of gray matter over time in certain brain areas.
What about hormones, the neuroendocrine system?
Research looks at the HPTA axis, hypothalamic, pituitary, thyroid, adrenal. And one of the most common physical issues found alongside bipolar disorder is hypothyroidism. There's also growing evidence linking bipolar states, both mania and depression, to increased inflammation in the body.
And environment, does that play a part?
Definitely. Especially for those with a genetic vulnerability. A stressful family life, adverse childhood experiences, these can increase risk. And for adults, stressful life events are well-known triggers for episodes.
Okay, so a mix of biology and environment. What about psychological factors?
Older psychoanalytic theories existed, like mania being a defense against depression. But with advances in neuroimaging showing clear biological underpinnings, those theories aren't really the focus anymore.
Right, the focus now is much more neurobiological. Okay, let's shift gears to the nursing process. This is really core knowledge for you, our listeners. Why is early diagnosis so critical?
Because it can literally save lives and prevent devastation. Early treatment helps prevent suicide, reduces substance abuse, minimizes relationship and work problems, and can help manage associated medical conditions.
So when you're doing an assessment, especially if you suspect mania, what tools might you use?
A useful screening tool mentioned in Varkarolus is the Altman Self-Rating Mania Scale, the ASRM. It's just 5 questions asking about mood, self-confidence, sleep, talkativeness, and activity level.
How does it work?
The patient rates each item. A score of 6 or more suggests possible mania or hypomania and tells you a deeper assessment is definitely needed. It helps capture that continuum of mood states.
Okay, so beyond screening, what are the key characteristics you're assessing for in mania? Let's start with mood.
You're looking for that expansive mood, elevated, unrestrained, maybe overly cheerful or inappropriately friendly. But it's often unstable. It can flip really quickly to intense irritation or anger, especially if their desires are blocked.
And behavior.
Oh, it's often hyperactive. Voracious appetite for socializing, spending, maybe indiscriminate sex. Constant activity, barely sleeping can become physically exhausted. Grandiose plans, maybe excessive calls or texts. Reckless spending leading to financial ruin. And a huge one is distractibility.
Right, you mentioned that. They start things but can't finish.
Exactly. Flitting from one thing to another. They might also be manipulative, push limits, use profanity, sometimes even bizarre clothing or makeup choices.
The book includes a powerful quote from K. Redfield Jameson describing that shift from euphoria into confusion, anger, feeling trapped. It really highlights the patient's experience.
It does, and their thought processes and speech patterns reflect that inner turmoil. They become disorganized.
Can you give some examples, like pressured speech?
That's when speech is fast, urgent, almost relentless, like talking from a fire hose. It's loud, rapid, sometimes incoherent, and they often show no interest in your response.
Okay. What about flight of ideas?
That's a continuous flow of accelerated speech with abrupt changes in topic. The links between topics are usually understandable, often based on wordplay or associations, but they jump around constantly, very verbose, like the example, "How you doing, kid? No kid around, I'm going home. Home sweet home." It just keeps going.
And sometimes it degrades even further, like clang associations.
Yes, that's more severe disorganization. They string words together based on rhyming sounds, not meaning. Like cinema I and two, last row, 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 row your boat. It loses logical connection entirely. As a nurse, recognizing these patterns is key. They signal significant thought disorganization.
And the thought content itself.
Can be sexually explicit, boastful. Often includes delusions, which are fixed false beliefs. Grandiose delusions are common, believing they have amazing powers, no famous people have achieved great things. Less common, but possible, are persecutory delusions, thinking someone is out to get them, like the FBI, or they're being punished by God. These can potentially lead to violence if they feel threatened.
What about cognitive function overall?
People with bipolar disorder often have high cognitive function before onset, but about a third experience lasting cognitive issues, like problems with memory or executive function. It's usually milder than in schizophrenia, but it affects daily life. This validates patients who complain about fuzzy thinking even between episodes.
That makes sense. Now, a really important point for nurses. Self-assessment. Dealing with mania can be tough.
Absolutely. The patient might be intrusive, make inappropriate comments, push boundaries. It can evoke feelings of discomfort, fear, or even anger in the nurse.
And it's okay to feel that.
It's normal. The key is to recognize those feelings, acknowledge them, and maybe discuss them with colleagues or supervisor. Understanding your own reactions helps you maintain professionalism and provide better care.
The book gives that case scenario with Jeff, the male nurse, and Jasmine, the patient making sexual comments. Jeff felt uncomfortable.
Right. And the team responded appropriately. They decided 2 staff members would care for her, and a female nurse would spend more time in her room, avoiding situations where Jeff was alone with her. That protects both the patient and the staff, addressing ethical considerations and safety.
Okay, thinking about NCLEX prep. For acute mania, what's the priority nursing diagnosis?
Almost always, risk for injury.
Why that one?
Because of the combination of poor judgment, excessive physical activity, potential dehydration from not eating or drinking, and possibly distorted reality from delusions or hallucinations.
Makes sense. Other diagnoses might include altered thought processes, impaired social interaction, self-care deficit, sleep deprivation.
Exactly, and the immediate outcomes you're aiming for relate directly to that risk, preventing injury. So, goals like the patient will remain hydrated, maintain stable cardiac status, get enough sleep, Demonstrate thought self-control, make no self-harm attempts.
And the planning phase in acute mania.
Focuses on medical stabilization and safety. Often, hospitalization is the safest place. Nursing care involves managing meds, decreasing physical activity, ensuring food and fluid intake, promoting sleep, aiming for 4 to 6 hours initially, and meeting self-care needs. Seclusion or restraint might be considered if safety is severely compromised.
Okay, let's move into implementation, what nurses actually do. You mentioned patients can be ambivalent about treatment.
Very much so. Many delay seeking help for years. Some self-medicate with substances, others minimize the negative consequences of their episodes, or honestly, they might be reluctant to give up the energy and euphoria of hypomania.
So for acute mania requiring hospitalization, what's the nurse's role?
Providing safety and external controls is paramount while medications start to work. Staff need to consistently set limits firmly, but calmly and neutrally.
What are some specific therapeutic communication techniques from the book?
Use a firm, calm approach. Short, concise sentences because their attention span is minimal. Be consistent, same approach, same expectations from all staff to reduce manipulation. Clearly state rules and consequences. John, if you can't control yelling, we will need to help you.
What else?
Listen to legitimate complaints. It reduces feelings of helplessness and firmly redirect their energy. Distraction is often a very effective tool when someone is manic.
And managing the milieu, the environment.
Keep stimuli low, maybe a quiet room away from the main activity. Provide structured, solitary activities initially. Offer frequent high-calorie fluids and remind them to rest. Redirect aggression early. Use PRN meds, or as a last resort, seclusion restraint if there's immediate danger. Monitor for lithium toxicity and secure their valuables.
What about basic self-care needs? They might neglect eating, sleeping.
Big focus area. For nutrition, monitor intake output, vital signs. Offer high-calorie, high-protein drinks and finger foods they can eat on the go. Frequent reminders are key. For sleep, encourage rest, keep the environment calm, maybe warm baths, soothing music. Medication might be needed at night, and definitely avoid caffeine.
Hygiene, elimination.
Encourage appropriate clothing. Give step-by-step prompts for hygiene tasks because they're so distractible. And monitor bowel function, offer fluids, fiber, laxatives if needed to prevent constipation or impaction.
Let's revisit Jasmine's care plan. What were some specific goals and interventions?
Okay, so for hydration, the goal was patient will be well hydrated within 24 hours. Interventions included offering those high-calorie drinks hourly, frequent reminders, tracking I&O, daily weights. The rationale links to cardiac status and managing distractibility. And evaluation showed she met this goal.
What about sleep?
The initial goal was maybe 3 hours of sleep the first night. Interventions were PRN meds, low stimulation environment, short rest periods, decaf drinks, bedtime routines. Evaluation. She didn't meet the 3-hour goal initially, but sleep gradually improved over days with consistent interventions.
And vital signs.
Goal. Vitals within normal limits in 24 hours. Interventions. Frequent monitoring, keeping the team informed. Rationale. Overactivity strains the heart. Evaluation. Met. The overall outcome was positive reduced activity, better sleep, able to engage in discharge planning. It shows that holistic, persistent nursing care works. Now, let's talk psychopharmacology. This is huge for nurses. For agitation and acute mania, you often see lithium or valproate used, sometimes with a second-generation antipsychotic like olanzapine or risperidone. Benzodiazepines like clonazepam might be used short-term.
The term mood stabilizers gets used a lot.
It does, but it's a bit of a misnomer. Most are effective for mania, but not all are equally effective for preventing depression. Lithium is kind of the classic, FDA approved for acute mania and maintenance.
But it takes time to work.
Yeah, onset is slow 10 to 21 days. So it's often combined with something faster acting initially. It helps reduce the euphoria, grandiosity, flight of ideas, irritability, anxiety. Patty Duke's quote about it saving her life really captures its impact for many.
The big thing with lithium is the therapeutic window, right? It's narrow and dangerous if levels get too high.
Absolutely critical for nurses to know. Therapeutic level is roughly 0.6 to 1.2 milliQL. Anything over 1.5 milliQL is getting into toxic territory.
Okay, walk us through the toxicity levels and what nurses need to watch for and do. Start with expected side effects, below 1.5.
Sure. Below 1.5, you expect things like mild nausea, thirst, polyuria, maybe some lethargy, a fine hand tremor. These are generally manageable. Long-term, there's a risk of kidney issues.
Then early toxicity, 1.5 to 2.0.
Now, symptoms worsen. GI upset increases. The fine tremor becomes a coarse hand tremor. Confusion starts. Muscle hyperirritability, poor coordination. Intervention here is crucial. Withhold the dose, get a stat blood level, notify the prescriber immediately. Dosage needs adjustment.
Advanced toxicity 2.0 to 2.5.
This is a medical emergency. You see ataxia, stumbling, gait giddiness, blurred vision, maybe muscle twitching or clonic movements, large output of dilute urine, seizures, stupor, severe low blood pressure, coma, risk of death from pulmonary issues. Requires hospitalization, stopping the drug, actively trying to get it out of their system, maybe whole bowel irrigation.
And severe toxicity above 2.5.
Life-threatening.
Yeah.
Convulsions, very little or no urine output, oliguria, death. Hemodialysis is usually required. The key takeaway is know the signs, monitor levels, act fast.
So patient teaching for lithium is non-negotiable.
Absolutely vital. They need to understand it's long-term, not addictive. Stress the importance of regular blood draws. 2 huge points. Maintain consistent fluid intake, about 1.5 to 3 liters a day, and consistent sodium intake.
Why sodium?
Because low sodium can cause lithium levels to rise dangerously. High sodium can make levels fall. They need to know to stop taking it and call if they have severe diarrhea, vomiting, or sweating, because dehydration increases toxicity risk. Also, check before taking diuretics or OTC meds like NSAIDs. Take it with meals, expect some initial water weight gain, and know who to call if they have problems.
What about anticonvulsants? They're used a lot, too.
Yes, drugs like valproate, carbamazepine, lamotrigine.
Yeah.
They were first for epilepsy, but work well for bipolar, especially rapid cycling or mixed episodes. Valproate, Depakote is very common now, maybe even more than lithium for acute mania. Need to monitor liver function and platelets.
Carbamazepine Tegretol.
Good alternative, especially for angry or paranoid mania, but requires close monitoring of liver enzymes initially and CBCs due to risk of bone marrow suppression or aplastic anemia.
And lamotrigine, the Mickled.
Primarily for maintenance treatment, preventing future episodes. The big warning here is a rare but potentially life-threatening rash Stevens-Johnson syndrome. Any rash needs immediate medical attention.
What about the second-generation antipsychotics?
Like olanzapine, risperidone. Used often in acute mania for sedation and mood stabilization. But the major downside, and something nurses must monitor and educate about, is the risk of serious metabolic side effects. Weight gain, diabetes, high cholesterol metabolic syndrome.
And treating bipolar depression.
Tricky. Using an antidepressant alone can trigger mania. So they're usually combined with a mood stabilizer. Lurasidone, Latuda, and ketapine, Seroquel, are approved, as is Symbyax, which combines olanzapine and fluoxetine.
Any integrative therapies mentioned?
Yes, omega-3 fatty acids, like from fish oil. Good evidence they help with the depressive symptoms of bipolar disorder, though not so much for mania. That old cod liver oil advice might have had something to it.
Now, the text brings up an important point about cultural competence and potential diagnostic bias. Can you explain that scenario?
Sure. It contrasts 2 cases. Jason, white, presents with classic manic symptoms, gets diagnosed bipolar, prescribed lithium, and Zyprexa. George, African-American, presents similarly agitation, grandiosity, maybe hallucinations, but gets diagnosed with a psychotic disorder, possibly schizophrenia, and only gets Zyprexa.
What's the significance of this contrast?
The source suggests this reflects a real-world disparity where African Americans are sometimes misdiagnosed with schizophrenia when they actually have bipolar disorder. The implication is huge. They might miss out on effective, often more cost-effective treatments like lithium and suffer longer. It really highlights why nurses need to be aware of potential biases and advocate for thorough, impartial assessment for everyone.
That's a crucial point for equitable care. Okay, what other key interventions are important?
Electroconvulsive therapy, ECT, is still a valuable tool, especially for severe treatment-resistant mania or rapid cycling. It's also highly effective for severe bipolar depression, sometimes more so than medication.
And teamwork and safety.
Absolutely essential. Given the risks, especially self-harm or impulsivity, constant communication and collaboration among the healthcare team are vital. Frequent meetings help prevent staff splitting where the patient pits staff against each other and manage the team's own potential reactions like fear or anger. Consistent limit setting is key.
What about seclusion and restraint? When is that used?
Only as a last resort. When there's imminent risk of harm to self or others, the patient can't control their actions, and verbal de-escalation or chemical restraint, medication hasn't worked or isn't appropriate.
There are strict rules around it, right?
Very strict legal and ethical protocols. It requires a written order, time limits, frequent reassessment. Nurses have specific responsibilities. Constant observation or monitoring, like every 15 minutes, offering fluids, toileting, checking vital signs regularly. Communication must be clear, direct, empathetic, reassuring them it's temporary, and for safety, never for punishment or convenience.
Support groups.
Invaluable. Groups like DBSA, Depression and Bipolar Support Alliance, or NAMI, National Alliance on Mental Illness, offer crucial peer support and education for both patients and families.
And health teaching and promotion is a massive part of the nurse's role.
Huge. You need to constantly reinforce that bipolar disorder is chronic, recurrent, and needs long-term management. Teach patients and families the warning signs of relapse, especially changes in sleep patterns. That's often the first sign of impending mania.
What else is key for teaching?
Avoidance of alcohol, drugs, excessive caffeine, good sleep hygiene is non-negotiable, coping strategies for stress, the importance of therapy group or individual for insight, skills, and adherence, managing potential weight gain from meds, and fostering that collaborative relationship where the patient feels like an active partner in their care.
Advanced practice nurses might also provide psychotherapy.
Yes, things like cognitive behavioral therapy, CBT, to target maladaptive thoughts and behaviors, improve adherence, manage stress. Interpersonal and social rhythm therapy, IPSRT, helps regulate daily routines and stabilize relationships. Family-focused therapy, FFT, improves communication and reduces stress within the family system.
Finally, evaluation. How do we know if the care is working?
It's continuous. Short-term, you're looking at safety. Are vital signs stable? Are they hydrated? Is behavior safer? Are they sleeping? Longer term, you evaluate medication adherence, ability to function in the community, stability of mood and relationships, use of coping skills.
And nurses contribute to quality improvement, too.
Definitely. There are standards, like the Bipolar Excellence Project mentioned in the text, outlining key performance measures, screening for mania, suicide risk, substance use, using appropriate meds, monitoring side effects like weight gain or blood sugar, providing education, offering psychosocial support. Nurses are key to implementing and tracking these standards.
So wrapping this up, what does this all mean for you, the listener?
It means understanding bipolar disorder is complex, involving biology, psychology, environment, and your role as a nurse is incredibly multifaceted, assessing, intervening, teaching, supporting, advocating, ensuring safety, promoting long-term wellness.
Right. It's not just about knowing the facts from the textbook. It's about applying that knowledge with critical thinking and, crucially, with empathy. Understanding these struggles deepens your ability to connect with and advocate for your patients.
Exactly. And on behalf of the Deep Dive team, thank you for joining us. Remember, as you continue your journey to becoming a mental health professional, you're building not just knowledge, but that invaluable empathy. Keep learning, keep asking questions, and know you're preparing to make a real difference.